Hey guys, Andy Austin, 19 years in interventional pain management. Let me ask you a question. How many of you have suffered or you treat people with lower back pain, particularly on the one side or the other, that buttock pain, even some pain going down the back of the thigh to the knee, and you try some things and they just don't get much better? Have you ever thought about SI joint dysfunction? And that's what we're going to talk about today. SI joint dysfunction, if you remember anything, SI joint dysfunction can be sneaky. It doesn't get blamed for enough of if it's problems. Mr. Disc, because it shows up so nice on the MRI, gets blamed for a lot of that chronic type pain. And although you may have a disc bulge on the MRI, the SI joint may be caused the problem. So let's stay tuned to this. We're going to talk over what is SI joint dysfunction, what's it feel like, what are the risks, see if some of this kind of echoes with you, and some of the treatments, most common treatments we do to help folks with SI joint dysfunction. This will be part one, and we'll probably do a part two going over some of the physical examination signs to help clinicians identify appropriately SI joint dysfunction. It's tough. Okay, so SI joint dysfunction, what is it? What's it stand for? It's sacroiliac joint. SI for short. You're going to hear me say SI joint dysfunction, SI joint disease. All those types are synonymous, okay? What is the SI joint? Well, if you look at my lovely artwork, and once I've seen on what I said on previous videos is I'm not an artiste, okay? But if you've been watching some other videos, you're starting to figure out what are some of these structures, okay? So this is from the back. This is from we're looking at the back, okay? This is your spine. That's L4 vertebral body. That's the disc. That's L5. This is the sacrum. That's your tailbone. These are the iliac crests of the pelvis. Those are the bony protuberances you feel when you feel your pelvis on either side of your abdomen. That's what these are right here. Okay, and those will be important. Okay, and what I want to show you is the anatomy, because it'll give you an idea on how difficult this can kind of isolate. Because in a perfect world, you'll just have just SI joint dysfunction, but a lot of times people will have a mixture, a combination. So what we have here is the L5S1 disc, okay? And then you have the facet joints. Previous videos we talked about how the facet joints are important. I didn't draw the facet joints at 4 or 5, but it doesn't matter. And then you have the SI joint. The SI joint is where the sacrum and the iliac crest connect, and they form a joint. Now that joint is not like a joint in your elbow or your shoulder. It's a semi-fixed joint, which means you have pretty tight ligaments holding that joint intact, but it can move, okay? And we'll talk about what causes this problem and what causes those injuries sometimes to the ligaments, okay? So SI joint dysfunction, so we can look at the anatomy by itself and tell, okay, we have joints, we have a disc, and we have another SI joint on either side. That's a lot of structures that could be causing pain by itself or a combination thereof, okay? Also too, SI joint dysfunction, when you get an MRI or when you get an x-ray, it may not always show a whole lot, okay, depending on the age of the patient. SI joint dysfunction can be acute, which means early on, sudden onset, has been happening very long, or it can be chronic. It's been going on for years and years and years. They've seen dozens of different providers, and they've tried a lot of things. It never has worked. So one of the risks, a lot of the causes for SI joint dysfunction, falls. And I'm talking about falls that may have happened 2 weeks ago. They come in having pain, that point right back there, where that iliac crest comes down and connects. You'll feel a little divot, a little dimple back there on that buttock. That is where the SI joint lives, okay? And so they may come in, they slipped and fell in the yard, and they're having this pain that they're just not able to get over. And so you get an x-ray, no fractures, but there's real tender over that SI. Falls, number one. Or on the flip side, they could have fallen 10 years ago, okay, and gotten over it, and all of a sudden now it's starting to creep in, starting to cause that that dull, aching type arthritic pain. Arthur's sitting in my joint. It's colder weather change, or it's raining like we've had this week. Starting to have that. That's a different type of presentation. So SI is real tricky, okay? Keep that in mind. Another cause, frontal impact motor vehicle accidents. The way I describe it to folks is, how many of y'all have a 15-year-old you're teaching to drive? Lord be with you. Moving on. So you're sitting in the passenger seat, little Johnny, little Susie's driving, and they're coming up on a parked car, and you're putting that foot through the floorboard trying to stop the car. Well, that's what happens with a frontal impact collision. When someone's coming towards you, you're putting that foot through the brake trying to stop. And that all that force of that impact goes all the way up, drives all the way up the femoral shaft, and hits that SI joint. This is the SI joints. Okay, this is the back view. The orange, I just put some orange in there so you can see it. SI joints, okay? So if you're sitting forward, femur's this way, and you're taking a collision this way, all that force is getting driven back to this SI joint, okay? And what's supporting that joint are ligaments, okay? And sometimes those ligaments become stretched or damaged, and you can have what's called hypermobile SI joint dysfunction. We'll talk about a little bit about that later. So frontal impact MVA's biggin', and that's talking about it could have happened last week or it could have happened 10 years prior. There's no way of knowing, okay? Also, we see a lot in leg length discrepancies. Sometimes people are born with the one leg a little bit longer or shorter than the other. Sometimes it happens after a total hip or total knee replacement. We're talking maybe a quarter of an inch leg length discrepancy. What'll happen is it'll throw off that pelvic balance, okay? So you can start digging that SI joint, and when people have SI joint dysfunction or arthritis in there to begin with, and then they have a leg length discrepancy, that can really irritate the SI joint on the affected side. By far, one of the most common, because SI joint dysfunction can affect young people and the very old, the whole lifespan, particularly ladies. Ladies, I'm sorry, it's just, we see SI joint dysfunction so much more in ladies than men. We have a lot of times it'll be in their early 40s, they had children in their mid 20s, late 20s. And a lot of times what we'll see are thinner framed ladies that may have had big babies, good sized babies, healthy babies. And had made a lot of questions. A lot of times I'll ask them, how many babies have you had? Oh, I've had 3 babies. Okay, were they big babies? Oh, the first one, oh Lord, yeah. The first one was a big one, and I didn't think she'd ever come out. Second 2, I had to have C-section. That tells me, okay, that was a lot of pressure on that pelvis to get baby born, and she carried it for a long time too. And if she's thin framed to begin with, a lot of that pressure, a lot of that pain a lot of that pressure can start stretching those SI joints over time, especially when baby goes through the birth canal. Just a little tidbit. Pregnancy is a big one. Also too, we see it a lot of times with people who have had previous back problems, like you had a herniated disc or a malalignment in the spine, and you had to have a lumbar spinal fusion. And you were doing great, and 6 months down the road, you start having this right buttock pain, that's pain going down the back of the leg. Oh my gosh, you mean to tell me that I had this big back surgery, I did great afterward, the surgeon was beautiful, it was wonderful, he did a great job, and all of a sudden I'm starting to have this pain again down the back of my leg. What's going on? It could be SI, because, okay, I'm gonna geek out just for a minute. Hang with me, don't leave. But if you're looking at this facet joint, say they fuse this, okay, and that's typically what they do. They'll fuse L5S1, okay, they fuse that. That's a fused vertebrae, okay, which means they put rods, they connected this to this, okay, so that's not moving, all right? You've increased the workload above and below that fusion. what I tell guys is, you know, when you go get that, you have to go get that rusty bolt, you go get that long handle wrench to get more torque on it. That's what can happen with the SI joints, okay? You've locked this movable joint, these facet joints, that's where they were meant, but you've locked them now because you had to. You increase the torque on the SI joints, the next movable, even if it's semi-movable, movable joint, okay? So you increase the torque on the SI joints so it can cause a flare-up of SI joint pain. And we just throw this in here, infection. Infection is very rare, but it's always in the back of a practitioner or provider's mind. Always watch for the very, very uncommon infection of the SI joint. And that's really any joint, really, septic knee joints, you know, that kind of stuff. So, so what we talked about, you know, the common causes, it could be a malalignment. Over the years, that SI joint has become out of alignment, either up, down, forward, back. Your good provider or therapist can evaluate you. Osteoarthritis can develop in there, all different kinds. And it's reasonably responsible because of the posterior ligaments have become stretched or damaged, so you start having that hypermobility of the SI joint. So if you go to therapy and they say, okay, I'm gonna put your SI joint back in line, and then sometimes they can use an SI joint belt where they'll kind of cinch it up and hold it there. That's what they're talking about, okay? That joint is moving in and out, and it's causing pain. So pain, sharp pain, well localized on the right lower back, buttock, going down the back of the thigh, rarely goes below the knee. For me, that's what sticks out in my mind is the sciatica is more of a sharp, burning, stinging pain, goes down into the foot when you're talking about L5 or S1. This kind of hangs out in that buttock area and that posterior thigh. That's kind of where it goes. But the big thing is, when I talk to people about SI joint dysfunction, when I'm evaluating them, what makes the pain worse? Is it worse with standing, walking, sitting, walking upstairs? SI joint dysfunction is worse with prolonged standing, walking, and walking upstairs. You can imagine, okay, if that's what's irritated and ticked off and your legs connected down here, the more you stand, you put more pressure on the SI joint. It shouldn't hurt you a whole lot when you're sitting down, right? Now, if you're having pain with sitting, people that have seen my other discogenic back pain videos should know. Comment, put it in the comment. Pain worse with sitting is a common sign of what type of problem? Put in the comment. All right, so your treatment options for SI joint dysfunction are therapy. You get a good therapist, chiropractor, physiatrist that is that like SI joint is their thing. You know, a lot of good therapists and chiropractors, they take a lot of pride in SI joint dysfunction, as they should. They are very good at it, and they can manipulate that thing, and if it's out of alignment, they can get it back in alignment. Hopefully, that'll help a whole lot. Okay, so therapy should always be one of the first things if you're suspecting SI joint dysfunction after your radiologic studies. But once again, your radiologic studies may not show a whole lot in SI joint area, okay? Oral medications, we've talked about that on previous videos, your typical anti-inflammatories and stuff like that, if that fits for you. Now, injections. If you've progressed, if you've tried therapy and oral medications, et cetera, you go down to injections. Now, SI joint injections, in my opinion, okay, I know I'm gonna get some comments on that, and please leave some comments. I think it's great. I think it's extremely important for folks to have SI joint injections under some sort of radiologic guidance, and I'll tell you why. And what I mean by that, folks, is you got to have something, either fluoroscopy, CT scan, that's kind of overkill, but CT scan, ultrasound, fluoroscopy or ultrasound. Watch that needle go into that SI joint, okay? Watch it go in there, okay? And I know some of the comments already, they're gonna say, dude, I've been doing SI joint injections for 10 years, and a one-eyed, one-armed monkey can do SI joint injections in the office. I get it. I get it. When everything works great, that's great. But if you do the injection and it doesn't work, how do you know for exact certain you were in the joint? Because we use these injections a lot of times for diagnostic criteria, because what we inject in the joints, okay? So if you're going to get the SI joint injected, you really need to have some sort of a radiologic guidance to watch you go in that joint and make sure you're in the right spot, okay? Research shows in the most experienced hands, they looked at different trials using contrast that they see under fluoroscopy, anywhere from 12 to 56%, that's all that was in the joint. Some studies showed only 12% were in the right place. At best, 56% of the time they were in the right spot. Okay, so in my mind, radiologic studies guidance of the SI joint should be the gold standard. And it is, and because if you do that and it helps, you confirm to you and everybody where that pain is coming from or how much pain is coming from. Okay, because on the patient side, it's very important. If you're going to have the SI joint injected, come in when the pain is present. You get the SI joint injected, and before you leave, you tell them, "Is your pain better?" "Yes, my pain is better." "Fine, sir or madam." Okay. The next question should be, how much better? Much better. But you get the drift. Percentage-wise, man, 80% of my back pain is gone. Boom, we're there. 80% of the pain is coming from the SI joint. Remaining 20% is somewhere in this nest up in here. And we'll get to that later, okay? Now, there's other pain procedures that we can do, but it's too much to discuss in this video. I will mention, in the most severe cases, there are things called SI joint fusions, where orthopedists in particular, some pain management specialists will provide that type of service where they actually fuse the SI joint. That goes back to those damaged ligaments. The SI joint cannot stabilize and you have chronic pain there, so the thought is we're going to fuse it and stop the pain that way. So those are just some options in treating. Ladies, I'm sorry, you're at higher risk. If you had big babies, 10 years later, you're starting to have some right lower back and buttock pain going down that posterior thigh, might be SI. Don't know. I can't diagnose you. I ain't gonna diagnose you over YouTube. But get with your family doctor or your specialist or your provider, nurse practitioner, physician assistant, whomever you see your primary care, and get their opinion, get their evaluating, let them evaluate you, and get the right diagnosis. Because there's no sense in living with this, right? Hope you enjoyed this. Now, we're gonna have a part two, which will go into some of the tests, physical examination, because I'm seeing some of y'all how much you like some of the physical exam videos, so we're gonna go into that. And part two. So subscribe, like, comment. Hey, thanks for watching. We'll see you soon.